this video, we're going to review fentanyl, its role as an analgesic in the pre-hospital setting. In our current review of the CME, we discuss how fentanyl is one of the best analgesic medications designed. Because if you're going to design an analgesic medication from scratch, you want it to be fast-acting. Fentanyl peaks very quickly within a couple of minutes. As well, it doesn't last that long. It usually lasts about 30 to 60 minutes. Again, it doesn't have significant amount of side effects, and the true side effect we should be worried about with opiates is respiratory depression. However, the best thing about fentanyl, at the dosages we give, it doesn't necessarily drop patients' blood pressure precipitously. So that's why they're removing the blood pressure parameter for fentanyl in the next iteration of the medical directives. So a patient could receive fentanyl if their blood pressure is 60/40 and then they are severe pain. So you can see we can combat this from multiple means. We can give them a fluid bolus. We can treat the underlying cause of their bleeding if they are indicated for it. And as well, we can give them optimal pain relief. So fentanyl is a synthetic opiate analgesic. Depending on the resources you read, it's approximately 75 to 100 times more potent than morphine. Morphine's the gold standard of opiates. It's been studied the longest, it's been around the longest. So if you look from a tangible example, 1 milligram of fentanyl is equivalent to 100 milligrams of morphine. That is why we dose fentanyl in micrograms. So fentanyl is truly not as vasoactive as morphine. Morphine is vasoactive because it has this pretty substantial release of histamine from mast cell, which overall leads to vasodilation. Fentanyl can lead to some hypotension and vasoactive properties, especially at high dosages. But if you look, it's like, okay, what does that mean though? Like, what's a high dose of fentanyl? Honestly, there is no absolute universal standard because it all depends on the patient, the dose, what medications are they on, and a slew of different factors. However, fentanyl's vasoactive properties also depend on how fast we push it, how do we administer it, but typically at the dosages we give, when we use small aliquot dosages to achieving desired effects, that does not lead to hypotension. If we give higher dosages or large dosages, especially if we fast push it and the patient's already on other medications that can lead to reduction in their blood pressure, that can lead to some peripheral vasodilation. That's why fentanyl is so beneficial in trauma. Especially if we aliquot dosages with them, we're giving them fluid bolus if they're still hypotensive, we can treat their pain accordingly and also reduce the side effects because it does not lead to this substantial release of histamine like morphine. It's not as vasoactive as morphine. If you look to higher dosages can depress our heart rate, but again, that's higher dosages, more like anesthetic dosages, and if we fast push it. So that's the key. At the dosages we give, especially if aliquot dosages, we're unlikely to drop the patient's blood pressure and we can treat their pain effectively. So we look at the different routes that fentanyl can be administered. Under our medical directives, it stipulates intravenous and intranasal. You can see how that can get confusing when morphine's written intravenous and subcutaneous, especially when everything else we have to think about on a potentially chaotic and busy scene. So that's just a good reminder to go over it. However, if we look logistically, the intranasal route for fentanyl is amazing, especially for pediatrics, because they actually recommend the preferred route for pediatrics for narcotics is intranasal, especially for fentanyl, because one, I don't have to do an IV, it's less invasive, and the intranasal route's highly vascular. It's quite bioavailable and it gets absorbed quite quickly and leads to peak desired effects pretty promptly. Even in adults, imagine I could just do a squirt of intranasal, give you a little top up, and then subsequently I get the IV, I can continue down that route for the tailored aliquot dosages of it. If not, you can continue with the intranasal routes. As a friendly reminder, it's just 1 mil max per nair per dose. So that's a good reminder for that. However, in the grand scheme of things, fentanyl is quite versatile on the different routes it can be administered. Patients with chronic pain can have fentanyl patches, and it's big in the army. It can be given through the lollipops for analgesic effects too. Fentanyl leads to analgesia because it leads to a state of euphoria. Euphoria is caused by this large surge of dopamine. So you get this amazing feeling, you're happy, you feel sensational to be a matter of fact, and overall that obviously minimizes the distress the patient's feeling. Furthermore, it also leads to anxiety lysis, which is analogous to mild sedation, because patients are going to get anxiety in this emotional response when they endure pain. So overall, an analgesic medication like a narcotic causes analgesia in two different ways. It's like, one, I put a state of euphoria to the patient. That means they feel amazing. It's like a warm hug coming over them. So that's why it can be addictive. It also reduces the emotional response people have to pain. Everyone has an emotional response to pain. My subjective experience would be different from each and every one of you. However, when we give an opiate like fentanyl, it leads to anxiety lysis. So I take away your anxiety or I diminish it to it's just like, oh, that feels pretty good. That doesn't bug me anymore. So I always give the analogy. It's like, imagine you have this screeching sound happening in the environment you're in. And fentanyl is kind of like these headphones that help protect your hearing and reduce the sound. So you may still hear it, but it doesn't bug you enough because you've diminished it so much it's to a tolerable point. So let's actually delve into how fentanyl exerts its physiological effects for analgesia. Mu-opioid receptors are responsible for pain, respiration, GI activity, temperature, and motivation and reward. Mu-opioid receptors are found widespread throughout the brain, but they are in concentrated areas in specific locations in the brain. Specifically, they're involved in areas that are involved in reward, emotional regulation, and our high densities are actually found in the brainstem, which are involved in respiration. And that is why the side effect of fentanyl at higher dosages, or if you're prone to respiratory depression, can lead to a reduction in your breathing status. Also, if you look at where pain processing occurs, the thalamus is kind of the central hub of that. This acts as a relay station that takes in the sensory information, such as the pain signals, and sends it to the cerebral cortex. And that's involved in how we respond to pain, how we locate it. So I say this is similar to the Amazon warehouse. That, imagine packages are coming in, it's like, okay, that package has to go over there. That package has to go over there. So overall, the thalamus is sending these signals and saying to these different areas of the brain, you need to go there and process this. And so you remember the pain. You locate the pain. If you look too, there's high density of mu-opioid receptors in the dorsal horn of the spinal cord. And this is where the sensory information of the body enters. So imagine I took an ice pick and I shoved it through someone's hand. If that happens, the ice pick in the hand has to be notified the brain. It's like, okay, you're injured. You need to have an emotional response to this. So this has a high degree of nociceptors or pain receptors in our hand. This will be transmitted to the spinal cord, will go up the spinal cord through the ascending pathways and go to the thalamus. And the thalamus, once again, takes in the sensory information and takes it to different areas. Now that we know how opioid receptors work, where they're located in the brain, and how pain occurs and how fentanyl can diminish it, now let's examine what can happen at the cellular level. Let's dig a little deeper. When fentanyl binds to these receptors, it's equivalent to flipping on a switch. The receptor changes shape, and this triggers a chain reaction inside the neuron. Fentanyl has a high affinity for the mu-opioid receptors, which are G-coupled proteins. However, this leads to binding to potassium channels, which leads to the efflux of potassium ions. As a result, potassium ions flow out, making the inside of the neuron more negative, or it causes hyperpolarization. Simultaneously, calcium channels are inhibited, and this reduces the influx of calcium ions. These ion channel changes decrease the neuron's ability to release neurotransmitters like substance P and glutamate, which are crucial for transmitting pain signals. Overall, fentanyl is a very potent, very effective analgesic medication. It is more potent than morphine, and we give it in a very tailored approach with aliquots. It does have side effects. The most common side effect that we are concerned about is respiratory depression, because we know the mu-opioid receptors are at high densities in the brainstem. Those are involved with our ability to breathe intrinsically. So if you have dose-dependent fashion of opiates given, that leads to the receptors become less sensitive to CO2, which is how we intrinsically breathe. They removed the blood pressure parameter because at the doses we give, aliquot dosages, very slow, does not typically lead to a marked decrease in patients' blood pressure. Overall, fentanyl is incredible at its ability to achieve analgesia through its euphoric effects and its anxiety lysis effects. It's fast on, fast off. And now that we have ketamine, if patients are unresponsive to the initial dose or they need something more, ketamine can lead to this multimodal approach where it's that I have two different medications that are complementary, they have different mechanisms, and when combined, they overall lead to opioid sparing effects and achieve higher analgesia.